morning to you specifically because I didn't necessarily see you coming in. I'm going to move through the first three items quickly, please. Item 1, happy with. Apologies for absence, George.
As far as I'm aware, it's only Louisa.
Okay, thank you. And any declarations of interest that we haven't already got recorded? I'll take that as no. Right, to welcome a new face to the board, a very welcome new face who's disappeared from my screen at the moment, and that's Clement Maywell. Clement, it's a warm welcome to you. Clement has taken on a role which is so significant in terms of our community services and engagement, and coming from a social care background, I think he's going to bring a particular dimension to the work of West Suffolk Foundation Trust. So Clement, the warmest of welcomes. I don't know if you'd like to say just a couple of words about yourself to introduce yourself to the board.
Thank you very much, Sheila. I'm a warrior. I'm a social worker by background. Have 20 years of experience in relation to working across health and social care. Really pleased to join the team here at West Suffolk in order to help deliver positive change for the local population.
Thank you, Clement, and we're going to see a great deal more of you in the coming weeks and months. So it's a very great pleasure to welcome you into us, and I hope everybody's being welcoming to you. Okay, thank you. Sadly, we have a farewell as well. You'll be all aware by now that our Chief Exec of 7 years, Steve, is stepping down. From a personal point of view, I've been a chair now for more years than I care to remember, but it's over 20. And you can imagine I've worked with a very varied collection of chief executives over that time. But I genuinely mean it that working with Steve has been very special. And if I think back to 7 years ago, when I was elsewhere, Suffolk was a small DGH, standalone little hospital. Well, not so little, but relatively little. And look at where we are now. Integrated with community, integrated with primary care, a global digital exemplar. You know, candidates come for interview and talk enviously of where we are digitally. We have a potential site for the new hospital, almost within sight of my window. Strategies revised, and we've played a key part in helping to form one of the more advanced ICSs, Integrated Care Service organisations. You brought us a sense of ambition, and we won't lose that, Steve. Your desire for excellence, your focus on patients and staff. You told us we could punch above our weight, and under your leadership we did. We will honour that and continue to do so. Clearly, we have to be realistic. The last 2 years have been somewhat challenging. Some things we haven't done well. And there are a lot of lessons that we, you, the Trust need to learn. And we will continue to learn, all of us, and continue to embed that learning. I can't finish without mentioning COVID, of course. It's the thing that's on all our minds a lot of the time. And to pay tribute to the way that the Trust under your leadership led through COVID. We don't know what the future of the epidemic is, but we know there may be more to come. Steve, you've always given ferocious energy, enthusiasm, and total commitment to West Suffolk. Compassion and commitment is at the heart of what you do, and it's the heart of what we all aspire to do for this Trust. I thank you for the work in the Trust, the work in the ICS, and I think that's really significant because that strategic thinking that is driving the change, it's not just us that are on the move physically in terms of the Trust, but also the whole system is on the move. And your input, I know, will find a great home in that movement. You have so much to contribute to the wider NHS, and your past experience, alongside the practicality of actually being at the cutting edge, which in a trust like ours, you are at the cutting edge in a different way. We all wish you well. Time to rest, time to reflect, and time to prepare for the next big challenge, which I know there will be. Thanks, Steve. It's been quite a journey. Okay. I will now take questions from the public. Liz, would you like to ask your own question this morning?
I probably will if I can find it, Sheila, but before I ask the question, can I just say a few words to Steve on behalf of the governors? Because obviously we've had to work very closely with Steve as well. And what some people don't realise is that beyond the hospital, Steve has also worked at the cathedral, on the cathedral council body, and on the risk assessment group as well. And those are those little bits that we don't always know about. Added to which, he has been there when Quint's house was built, the residences, the upgrade of all the wards. I could go on and on and on. But the other thing that I would like to say is more the personal touch, donning the uniforms and walking the corridors, wheeling the trolleys, in the bins, and all those things that I think, you know, we are very grateful for. So, Steve, on behalf of the governors, I know we get a chance to say this again in person, I hope. And every time I've been into the building, I've missed that because you've been too busy, as always. But you know that we're very grateful to you in all that you've done. So now, sorry, Sheila, I'm going to have to find my question. Because it's actually on, I only sent it.
I think I've got it, if you would like me to read it.
Can you read it? Sorry, yeah, I didn't, you always read them and I thought, I'll leave it to you again.
Well, I knew you wanted to say something, so I'm just trying to find it.
Yes, thank you, Steve.
Thanks, means a lot, Liz, thank you. Pass on my thanks to the governors.
Here we go. Here we go, and I think we will probably you'll get some answers to this later in the agenda, I think, but I'll ask Paul in a moment. Can I take up the point about junior doctors' experience, please? As we continue to realise the effects of COVID pandemic, can we be assured that we will be assessing and recording the inexperience of the new cohort of junior doctors arriving in August? It is totally understood as to the reason for this, but have we prepared additional support to help them and our patients? Now, Paul, I don't know if you can answer that. I can't see you on screen at the moment.
Yeah, I am on screen, and I'm happy to pick up that question either now or later in the agenda. So,
is there somewhere obvious you can pick it up later in the agenda? Because if not, I'll get you to answer it now, Paul.
So it does come under the Guardian of Safe Working quarterly update.
Okay,
So
Liz, are you happy we pick it up there?
yes, of course.
Yes, that's where I saw it, so that I'm more than happy for it to be picked up there.
That's fine, thank you. I haven't received any other questions. Joe, your hand is up. I will take a verbal question if you've got one.
Thank you very much. The first one is an observation, because governors and members of the public don't speak when the minutes are reviewed. Can I just ask for information, and to avoid any doubt, that the second question under 21104 was actually a question that I asked, and as Liz was mentioned by name in the first question, I'd be really grateful if that could be amended to include who asked the question. And my actual question today is really a question about our focus, and whether there's any information that Steve or you can provide, or other board members can provide, about a very high profile response to long COVID in terms of people's responsibility in the board going forward. Are there any plans to actually really focus one person having, and it's a board responsibility, but I think it's something we've discussed in various meetings, as governors with NEDs and others. Is there likely to be a focus there that recognises for staff and for the board and for the trust that long COVID, or whatever it's going to be called in the future, needs to have that preeminence? Thank you. Thank you.
Jeremy, I thought I was going to pass it to you. You beat me to it.
Well, somewhat fortuitously, I had long COVID in my paper, so we will definitely talk about it.
Joe, we will make sure we pick it up. What we haven't got is an Ed champion, in effect, but actually I think myself that the whole board should be taking responsibility for this one.
Actually, Sheila, I slightly disagree. So we have Richard Davis as Wellbeing champion.
That's true.
And as you will see in my report, Richard was personally involved in a meeting, meetings that took place in June to bring people together as to how we support our staff with long COVID, and I'll talk about that some more under my paper.
Yes, you're right, Jeremy. That does fit under his remit. Okay,
thank you, Jeremy. Save me from coming in, and just to say that I will continue to focus my attention on long COVID.
Thank you, Rick. Thank you very much indeed. Can I move to review of the agenda? I am going to move the nursing report up because Dan Spooner has work to do elsewhere, so we need to take that early. So I'm going to move that up when we get to I'm going to take it before item 10, if that's all right with you, Sue, and Dan, if he's in the room, but I'm not sure he is at the moment.
Thank you so much.
No problem at all. And I will move potentially other things up to enable clinicians to see patients. That's, after all, what we're here for. Minutes of the previous meeting. Joe, we've noted your comment. Can we now move to those minutes, please? And I'll take them page by page. Please, can you put your hand up if you've got an issue? Page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Well done, George. Completely clear record for that one, apart, well, unless you count Joe's, of course. Board action points. If we could move to the first page of it, which is 24 of convene. The first item is actually scheduled for today, so if you're happy, we'll come to that in the community service leaders report, okay? The second one down, the date has passed. This is the IQPR. I don't know if anybody wants to. Helen, you're going to advise of revised target date.
So just this issue, we've struggled, Sheila, because of needing Joe, who, as you know, would be responsible for this, to move into CRT. We've been trying to recruit to backfill her post to allow us to progress this. Joe is actually interviewing today to do that, but she's also advised me that if those interviews for a substantive appointment are unsuccessful, then she has an interim lined up to do the work. And the primary focus, the initial focus of their role, will be to do the work on the IQPR, both to bring it back in as a full report and, where appropriate, to update some of the metrics that we feel we need to change.
So we haven't got a revised target date yet?
No.
Okay.
But I think we need to get the person in and let them have a look at the scale of the work and then get a realistic target for improvement, if that's okay.
Okay, I think that's fine. I see no indications of hands up. Sooner we get a date, the better, though.
Yeah.
The 1933 is on track as part of the Trust Safer Staffing Review. That needs an update as well, Sue, in terms of date.
So Justina, our Deputy Head of Midwifery, started this week, which is absolutely great news. And she'll be working with Dan and Sharon as Head of Paediatrics and Karen to do that. So it is part of our sort of business as usual. I'm not sure we need to necessarily keep it on as an open action unless people would like us to, but I'll take advice.
I think what do the board think? My view is probably we should keep it on because we can't sign it off as complete yet. Although it needs reviewing, okay?
Well, the question is, consider how neonatal staffing is reviewed in the context of the wider maternity service, and that was dependent on the Deputy Head of Midwifery coming in and working with the Head of Paediatrics. So we'll provide an update next month.
I think that's the best way, and then we could hopefully take it off.
Yeah.
Okay. The SPC chart report's going to Insight on Monday, so you're happy to accept that's on course. We can't see it today, but it will go to Insight on Monday and be discussed there.
So it will be picked up, Sheila, in line with Helen's report around the appointment that we're making. So as well as considering the metrics, that appointment will also develop the SPC charts to go alongside that. So all of that really sits together under one action.
Okay, that's fine. So we know what to bring those together really into one. Thank you. Chris, you've got your hand up. Chris, you're still on mute.
It was when you asked anybody on the board to comment on 1933. Sorry, it's because there are so many of us here. It's difficult to see the hands. I think we need to think very carefully in terms of our board agendas about what can reasonably be done and should be done at the committee stage. And it seems that something like this, actually, we should be charging committees to keep an eye on this and report back to us. It's just that, you know, a lot of these are sort of matters in progress. I think the outcome is not in doubt. It's a question of when they're actually delivered. So, you know, that's what I would recommend.
It's a good point. Thank you, Chris. Thank you. Okay, the rest of the items on page 25 of convene, 2 of the 3 pages are green. Is there any item there that anybody wished to raise any issues about, give us any more feedback on? I'm going to take that as no, as there's no indication of hands. And on the final page, we have the ward accreditation programme, but we have a future date now, which is a little way ahead. Is everybody happy with that one? And the other 3 are green. I'll take any questions or comments. Okay, thank you. Okay, and the final page, all items are complete. Unless there's any queries on those, I'll take those as okay. Right, I'd like to move now to the staff survey. Staff story rather, and welcome Natalie Bailey here, as well as Sue, who are going to present you with a staff story. Natalie, warm welcome to the board.
Thank you.
And thank you for inviting me. I'll try and show my screen. If not, we've got a backup plan.
We can see you, if not the screen yet. Yes, we're there. Brilliant, Natalie.
Okay, so thanks for inviting me. I'm Natalie Bailey. I started in the trust last January. It was initially going to be 3 months covering medicine and then on to mental health. But with the COVID pandemic, I ended up covering medicine for years. So I've started in this role since February. So the background to this role, I won't go into too much detail because of time. But basically in 2011, the Coalition Government published mental health strategy, no health without mental health. And that set out the government's plan to improve mental health and wellbeing of the population. And that's around the principle of parity of esteem, where mental health is given equal opportunity to physical health. And then that was enshrined in the Health and Social Care Act 2012. And then other policy developments have included the 5-year review of mental health in the NHS long-term plan. In 2017, there was a National Confidential Inquiry report published, and this also highlighted the need to bridge the gap between mental health and physical health care in general hospitals. And then between September 2017 and March 2019, the CQC completed a really in-depth assessment of services and community trusts. And that includes all sorts of areas from ED, medical wards, maternity and paediatric services. But what they found was that people face barriers in accessing help at time of crisis. And that acute trust did not always see mental health care as part of overall provision of care. In emergency departments, patients were not always provided safe and therapeutic care. There was lots of work that needed to be done on staff education, governance, and the Mental Health Act. And staff reported to CQC that they felt unsupported and unprepared to meet mental health needs of patients. Basically, they came up with lots of recommendations which were system-wide. That was local authority groups, integrated care providers needing to work together, improving trust-wide systems with SLAs, looking at the commissioning, and then the trust level, looking at having a mental health strategy, making sure that mental health at the board level. Making sure that they recognise quality standards, and really involving the patients, and then supporting staff that the training should be provided, and giving them the necessary skills and confidence, and that better mental health care should be provided alongside better staff wellbeing. So it was really a great opportunity for me to undertake this role because everything that was highlighted in these reports matched my vision. So whilst I worked for 30 years with patients with mental health problems, having a personal experience from somebody attending General Hospital with an acquired brain injury and then subsequently needing mental health support, I really wanted to get my foot in the door. So yeah, thank you. So where are we with the trust? So mental health is on a continuum. So we've got wellbeing at one end and severe mental illness at the other end. And you can see we've got a psychiatric liaison team within the trust. And what we can see straight away for this year is that there's been a steady increase in the amount of referrals to psychiatric liaison team. It's absolutely massive, and I would like to say this is just the tip of the iceberg. So these are the people that are presenting with severe mental health problems, but as we know, all of our patients and all of our staff have got mental health needs. But it just gives you a bit of an idea. So undertaking this role since February, it's been a busy few months, and I just wanted to highlight what I've been doing. So I've set up a mental health transformational group. It was set up in March, and it meets every 8 weeks. With its aim to ensure charity teams mental health, physical health, and this is attended by divisional representatives, safeguarding, allied health professionals, medics, nurses, safeguarding, and this group's going to be accountable to the improvement group. And that group is very forward-thinking, innovative, and we make sure that our actions are met. The other bit of work that we've been doing is agreeing the SLA, which is a requirement between West Suffolk and NSFT, and that's completion. And they're going to basically provide us with our mental health administration support, oversight scrutiny. And already they've been working with us on a grace favour because they were very close to signing that off. And now we use the correct legal frameworks. Patients are having their rights read, having access to advocacy, and able to appeal against detention. And the mental health policy will be implemented, and we've already started staff training on that already. Starting at the front door, improvements have been made to our risk assessments, and I've also been working very closely with Suffolk Police around a voluntary tender form to make sure that information is shared and communicated so that we know who we've got on the department to make sure their needs are being met. And we've also been updating our 136 policy to reflect when our emergency department can be used for patients without physical health need. And we're also making great headway in having an assessment room, which is classed as a safe room, quiet environment for patients with severe difficulties to be seen. In AAU, we've introduced a safe handover form, so we get many patients from mental health services attending for their physical health needs, and this is around communicating so that we know what their needs are and that they can be supported safely when at the West Suffolk. In paediatrics, we've progressed the psychiatric liaison team, and since April of this year, they're now seeing people under the age of 13. And we're working very closely with Rainbow due to an increase in young people attending with mental health needs. Education training started a needs analysis, and I've also been providing tailor-made training. So we did actually voice training, more of an awareness session. I've been supporting the RCN, our security team, who work very closely with me and ward staff. They basically identify what the difficulties are and then I provide the training. And I've also been working with West Suffolk on the training needs of all of the population. That includes hairdressers, everybody. And we've rolled out a week of training on compassionate care for young people within the trust. So lots of NAs, staff on the ground, have been doing the training to support paediatrics. And a couple of weeks ago, positively mandatory training has agreed. So I'll be setting up an e-learning package, which hopefully I'll get up and running by November. The mental health guidelines, I've been reviewing all of those, and that's going to go out to everybody. So that's co-produced with service users with experience and our staff. Because it's them that will be using it, so it's definitely not a top-down approach. And I'm also working on a mental health strategy, which is going to align with the new trust strategy. And again, that's going to be co-produced. So with psychiatric liaison and NSFT, we've got closer working. They now come to our safety huddle every morning, where we discuss our most vulnerable patients. They've also been helping with the policy creation, the new risk assessments, training. Record sharing is imperative for safe practice. As I say, they became age inclusive the 1st of April, and hopefully in August they're going to be 24/7 on site. So whilst they now do provide 24/7 care, they're going to be actually based on site at night, because we felt that was safer. Lots of learning going on, learning from incidents. I've reviewed all the incidents that have included people that have had mental health problems over the last 3 years, because I wanted to check that we're still meeting the actions, but also identified actions that hadn't been noted originally, and then putting things in place to make sure that it's safe. We've looked at the missing persons policy review, handover and communication. And I'm also a great believer in learning best practice as well. So lots of sharing. There's been a huge increase in patients that suffering from eating disorders. And not only have we learned from Addenbrooke's, other hospitals nationally, we've also then internally been sharing practice between Rainbow Ward, F12 and currently G5. And last but not least, lots of quality improvement projects going on. So I've produced a Wellbeing recovery plan with a 12-year-old Rainbow Board. And we're also going to be doing a QI project about how we can increase the amount of referrals for our older people within the trust to the psychiatric liaison team. We've noticed that perhaps that's not as high as it could be when we work with staff. And that's a snapshot. Thank you.
Thank you. That was really helpful. I've got a lot of notes, so I'm not going to say any more at this point. I'm going to hand over to Richard and hope he's not echoey.
Thank you, Natalie. That was just superb, really impressive, and a huge amount of work going on, which is very appropriate. I'm interested in the idea of the importance of parity between mental health issues and physical health issues, and that is clearly something that's dogged the health service for many years and society in general, and requires culture change more than anything else. So I'm just wondering, since you've been working with the Trust, what's your sense of where we're at on that cultural journey? How receptive are people to your ideas? How receptive is this organisation to that idea of parity?
Extremely receptive, and I would say that's from floor to board. You're very welcome to join the mental health transformational group, and then you'll be able to have like a first-hand view of the enthusiasm and passion. I say we've had 3 now, and everybody comes back and they've met their actions. It's not, I never want that group to become what I'd call a repetitive group where you talk about the same things. So this is very much about based on actions, and people are coming back, and it's really spreading. People are excited. And the wards now are going to have mental health champions, so that it's, because this is about the patient, it's not about us. So really receptive.
Thank you. That's great. I would be quite interested in at least joining one of your transformational group meetings to see what goes on. So please send me an invite. That'd be great.
Yeah.
Thank you, Natalie. I think what would be really great is if we could have a case study of, an individual who's been through the system where perhaps one where it hasn't worked quite so well and what we've learned from it.
Yeah,
bring it down to real patients, real people.
Yeah.
Chris, obviously you've got very recent expertise in this field.
I have, Natalie, delighted and really interested in everything you had to say, and I'd love to come and talk to you and learn more about it, particularly because I've spent 8.5 years chairing a mental health trust in Hertfordshire, so a lot of this is very familiar to me. A couple of quick questions that I'd like to ask, because you're moving at pace, and I can see you're putting a lot of things in place which seem to me to be absolutely sound. Within the context of the presentation, it's a little bit difficult to talk about people who present who are really challenging, deprivations of liberty, people who are sectioned under the Act. Like to understand a bit more about, do we actually have a place of safety in our emergency department, or do we have to then get people to a Section 136 suite, and who in fact is doing the assessment on those people? The mental health practitioners, the authorised ones who are actually doing the sectioning. That's the one thing. Delighted to hear that the RAID team, sort of the mental psychiatric liaison team, is going to be 24/7 and more present on site. Question, what about mental health support for our staff? And the other question is, what about people with learning disabilities, which I didn't hear about?
Yeah.
Sorry, lots of stuff, but
yeah. So with the
I'm passionate about it.
I'll try to remember that in order. So with the 136, predominantly we used for people that are needing their medical needs met. We've done a lot of work with NSFT to make sure that their 136 suites are available, but we have been using ED as a place of safety if we have to, and that's based on a couple of national incidents where harm has come to people in the back of police cars. So that's been a recent agreement, and we're reviewing that will be embedded in the 136 policy. With our staff, so my role is predominantly patient facing, but I work very, very closely with Emily Baker and her psychological staff wellbeing support team. And so that's her focus with her team, but obviously it does dovetail, and staff do seek me out, and I will work with them and then direct them to Emily's team, but of course I am here for staff as well.
Yeah.
With learning disabilities, we've just appointed a learning disability nurse who I also used to work with in the community. And we're also working very, very closely today together on using the Green Light toolkit reasonable adjustments, and working closely with the CCG.
Great, that's really kind. I'd love to come and talk to you. A great
yeah, lovely.
Okay.
Thanks, Chris. We now have a champion in Richard and a resident expert in you, which is great. I've got Kate, Alan, and then Helen. Kate.
Hi, Natalie. I'm Kate Walton. I'm the Chief Operating Officer of the CCG, and I lead our local alliance. And just wow, really, in terms of being able to pull even a fraction of that off in the limited time that you've actually been enrolled. It's very, very exciting. The point I wanted to make, or the question I wanted to ask, are you linked into the work we're doing at the moment in terms of bringing the community mental health model online? Because I think our recruitment for that is going well in terms of having a mental health practitioner in each of the practices. And I think utopia might be being able to create the network strong enough that when you've got an inpatient, we can safely transition them in and out under the kind of one team approach. I think it would be lovely to sit down and make sure, A, that we've made that link, or if there's anything else you need, that we can try and work that through. And just the other point, we had a presentation at the CCG board on Wednesday from some of our voluntary sector partners, just about how they can add to that kind of that journey and just the continuity in terms of building the relationships. And again, it would be lovely to feed some of that in, because if they've got established relationships, that might help with some of the interactions where we've got inpatient stays. There's so much to do. It's very exciting.
Yeah, there is. So whilst I'm aware of all of the community things, so I link in with Wendy and Leanne Nunn, and it is something that I do need to connect more with.
We can do more local than them. Let's link up.
That'd be brilliant.
Okay, a useful link created. Alan, and then Helen Beck, and then Clement, and then I'm going to probably have to wind this up. Fascinating, there it is. Alan.
Hi, Natalie. I'm also amazed at the progress. It's fantastic. What I really like is the idea that this can become business as usual, and that rather than you being a sort of niche thing on the side, that Helen, Paul, Sue, Clement, all the team actually include mental health issues just as normal, really, in their reports, when it's appropriate. And I really like the fact that it just becomes part of normal life at the trust. So thank you for helping us to do that.
Thank
you, Alan. And Helen?
I think my comment sort of segues very nicely into that, Alan, because I was just going to kind of pay tribute really to the impact of this across the organisation. I think with mental health issues in the acute, we hear about them and know about them when we've got it wrong, when there's a problem, when there's a delay, when we can't be seen, when our staff can't manage them. And I think it's well understood now the significant increase in mental health presentations. But actually, the combination of Natalie and an enhanced site liaison service and really close working really does mean that unless there is a real issue with securing a mental health bed, our ability through ED, the number of times we don't quite get it right, I think is much reduced. And the other thing I was just going to say, it is now really common to come in the morning to say somebody's had a difficult night, struggled with a particular patient, and the next sentence is either Natalie's already been or I'll get hold of Natalie. And it is becoming business as usual in the organisation. People don't see this as a niche thing on the side, but as a core result. Really well done, Natalie. It's a great term.
Thank you, Helen. Clement?
Thank you, Sheila. I would really like to echo that, Natalie. I think this is really positive to see. I would really welcome an opportunity to catch up with you in order to see how we can ensure that level of resilience, firstly in the community, as Kate stated, but also in planning for liberty protection safeguards.
Yes.
And preparing that really well so that from April we have a very good plan that we'll be able to implement.
Thank you, Clement, and thank you for pointing that out. So, and then I'm going to wind up.
it's just very quickly, Sheila, to say that to thank Natalie for all the work that she's done, but also to acknowledge it's not just the patients she's looked after. She has been an absolute immense support to all of our staff who have also been struggling with how to look after these patients, and that in itself has had a significant impact on them. So it's just to recognise the sort of holistic care that she's provided to everybody involved, and to thank her for that, because I know sometimes it's meant that she has had to absolutely go above and beyond. So thank you, Natalie.
Thank you, Natalie. And you can be very proud, I think, of your work. And I thought one of the nicest comments you made was that it is becoming business as usual from ward to board. And if it becomes embedded, then it is what happens around here. It's the way we work, and that's what really, really matters. And these are some of our most vulnerable patients, and I think we have struggled in the past to know how to best care for them. But thank you, because not just for running yourself ragged doing the job, but for making sure that everybody around you has can develop those skills and that confidence, because often it's confidence people are lacking when they're dealing with this particular group of patients. So thank you, Natalie, very much, and thank you for coming to board and presenting.
No.
Really appreciate that. Thank you. Thank you very much, and thank you very much indeed. And on the agenda, please, to the Chief Exec report. Steve.
Thank you, Sheila. Maybe I should just start by saying what a wonderful presentation that Natalie's just given. I think it underscores the transformation journey that we've been on since I arrived, actually. We're no longer an acute provider. We've got that increasing focus on mental health. We've had the focus on integrating with community that Kate has really accelerated, and we've welcomed today Clement, who further will help us really drive that integration with our social care partners. And even with Helen Jopling, who has done a tremendous amount of work through the pandemic, we now have public health as part of the organisation. I think it just underscores some of the transformation that we've been trying to achieve over the last few years. And just can I say what a privilege it has been to lead what I think is an absolutely amazing organisation, an amazing team, and I'll say a little bit more about the team shortly, but also what amazing staff and volunteers. Liz, you mentioned my going back to the floor, and it's been a real privilege to work alongside porters, physios, doctors, nurses, our allied health professionals, our community teams, our district nurses who are going out in really difficult conditions. It's been great to go back to the floor in the laboratory and get them back in-house. And I've really enjoyed the time that I've had going out, seeing the challenges that our housekeepers, our internal staff who work in the kitchens, how hard they work. It's been a real privilege, and as many of you know, my family has seen firsthand. So my son's had 3 pneumothoraces while I've been here. My daughter has been treated here, and Adam Brooks, my father-in-law, was treated with tremendous care and compassion when just before I started. I know that our staff go the extra mile for local people, and it's been a real privilege to lead the organisation over the last 7 years. But the last 18 months has been difficult, and everyone knows around the well-publicised challenges following our internal investigation, and we were all massively disappointed with the CQC report. I've taken full responsibility for the failings identified in the report, and I've apologised to staff who've had the hurt caused through that internal investigation. we've yet to see any of the external review, either in draft or final form, but it does probably make sense to step down now. There's a lot of hurt that's been caused, and I'm deeply sad about this because I really, really care for West Suffolk. You know that. It's a great place to work, and that put us in the spotlight for the wrong reasons. And we have been moving forward since that report, since the CQC report, and we've had a pandemic to deal with. But now is a good time to step down and allow the organisation to keep moving forward. I think it's an amazing executive team, and we've got some of the strongest leaders I think that we've ever had. I want to say a big thank you to Craig. You've been my deputy. You've been absolutely amazing. I'm so grateful for what you and the team have delivered in terms of our financial both performance, but also how you and the team have helped us transform our ageing infrastructure. We have an updated emergency department. We have got a new acute assessment unit, a great cardiac centre, a great urology unit. We've got new sterile services. We've got more staff accommodation. We've got staff parking, and that's you and the team alongside trying to deliver quite a profound digital transformation, which we're all immensely proud of. Helen, you have done absolutely amazing in terms of leading through a pandemic. You have led that. We've been at the sharp end at times when it's really hairy in terms of managing on a day-to-day basis. Some of the the challenges that we face. We've already talked about Natalie being down in ED and at the bed meetings. You're there. You've led absolutely tremendous, and I love working with you, Helen, as you know. Jeremy has done such a great transformation on our culture since he arrived, and we'll hear so much more about that. But a revised HR policies, additional investment in the HR team, new freedom to speak up guardians and champions on the way, and really a lot of action that's been taken in response to our most recent staff survey and some of the issues identified by the CQC. We also should say a big thank you to Richard. I know he's not here today, but Richard, I think, has been an amazing trust secretary and has kept us all on the straight and narrow. Sue, you've underscored a real focus on improvement since you arrived, addressing many of the CQC concerns, but moving beyond that to really ensure that we've got that focus on doing the best care, the right care all the time. Paul, you have had a real focus on the health and well-being of our doctors, and that, I think, has been absolutely so needed. We know that many of our doctors are approaching burnout in terms of how hard they're working, and you've, I think, enabled us to really have that focus on them, and those doctors just underpin the high quality care that we and many of our staff deliver. Kate has, I think, been an amazing addition to the team, and I think increasingly the blurring of the organisational responsibilities across the community teams is evident. So thank you for that, Kate. And Clement, you will bring fresh perspectives and help us move beyond being just a health care organisation and really underscore our focus on health and care. I'd also like to thank you, Sheila, and I'd like to thank Roger, because without Roger appointing me and without you supporting me, I wouldn't have been able to do what is inevitably a really challenging job. We have a new strategy on the way, and we have a new hospital on the way, and we have a great team and a great board here. So it's been a real privilege to work with you all. I'm looking forward to a little bit of time off. So I've got lots of unused leave from the pandemic. So I will be handing over the reins to Craig very, very quickly and taking some much needed time off, and looking forward to new challenges. I've learned a lot, and one of the things that I've learned especially is how having the right people around you, you can do so much. And thank you for having me. Thank you for supporting me. I'm sorry when things have not gone quite according to plan. We've tried to put those right, and I think we're on the journey to putting those things right. And I look forward to West Suffolk being in the headlines for the right reasons in the future, and you will remain dear to my heart. Thank you for having me.
Thank you, Steve. It seems a little mundane after that to ask if anybody has any questions for Steve on his report. I'm going to take that as read then. I think that would be difficult to follow, and thank you for being here, Steve. Right, in which case, can we now move to the mundane? No, sorry, Sue, that's the wrong thing to say about the nursing report, isn't it? Can we move back to normal processes? So could we move to the nursing report? That's item 13.
Yeah.
So,
I'll hand over to Dan, he's here.
No offence taken, Sheila. Thank you very much. Taking the paper as read, a couple of highlights to pick out from this paper reporting on June's staffing fill rates and activity over the month. First, to note that fill rates have remained reasonably static on month, with as a trust maintaining over 90% across all of our shift profile. There are some areas of exception, and they are captured within the paper and found in the sickness has remained pretty much static this month, and also as has self-isolation. In preparation for next month's report, I would just like to raise how challenging it's been over the last couple of weeks as we found ourselves with increasing numbers. It's a little bit of a comparison prior to coming to this meeting on last week's activity and a week in June, and we've seen around a 63% increase in self-isolation and staff being contacted to self-isolate, which has added short-term and short-notice challenges this month. But obviously, I will report that next month. Of note as well, following 4 months of sustained improvement around our substantive staff numbers, we have seen 2 months in a row where that substantive number has dropped slightly. Excuse me. So we are reviewing our recruitment and retention procedures with the HR team to make sure that is as robust as possible, and we've recommenced our recruitment and retention meetings. Also, in addition, we've scoped our capacity to continue our overseas nursing pipeline, which has been 5 a month, and we have worked very closely with the education team and asked a lot of them to increase that cohort to 8 nurses a month coming from September. Which will bolster that pipeline a little. Other highlights of note is around our nursing indicators, which are found within the paper, and I'm pleased to report that we have seen 5 continual months of sustained improvement on hospital-acquired pressure ulcers, which is fantastic. And June saw only an incidence of 13 within the organisation, and none within surgery. So really great achievement, and I would like to just highlight that to the board around the great work that's been going on with the ward teams and the tissue viability teams. And I will take any questions on that.
thank you, Dan. Are there any questions? It sounds as if we have been quite hit by the pandemic, like everybody else.
It's been a challenging couple of weeks. And those notifications come very short notice, so it's a lot of mitigation and juggling last minute. The matron teams have been mitigating across the organisation extremely well, and having been on call this week, thankfully I've handed that baton over this morning, but it has been a challenging week for staffing and the trust in whole.
Is there any sign of it improving?
For staffing, not at the moment, no.
Ah. Okay. It's going to be a difficult next couple of weeks then, by the sound of it. Alan.
Yeah. Hi, Dan. Do we normally ramp up the RN staffing for the winter? And what are the plans for that for this year? When does that start, if necessary?
So we don't necessarily ramp up the staffing in regards to the substantive numbers specifically for winter, but we do have we do increase our nursing overall establishment, if you like, not necessarily substantive, with the opening of winter wards. We did that successfully last year, and we're now planning with the the winter planning team to reinstart that again. So that will be, it does add additional strain to the nursing team because it is spreading us a little thinner. But if we do that with enough notice, it is a less bitter pill to swallow, if you like.
Thank you. Good question, Alan.
Thank you.
Because winter, maybe we are predicted quite a difficult winter, I believe. Surprise, surprise. If there's no other questions, Sue, I'll come to you, and then are we going to take the strategy now while Dan is with us? Sue.
Yes. Thank you, Sheila. It's really just to acknowledge and recognise, and I know Dan's already said this, but the nurses on a day-to-day basis are moving and juggling and supporting each other incredibly well. And without their fantastic teamwork, we wouldn't be able to deliver the care that we do. So I just want to recognise that it has been extremely challenging, and that often nurses are being displaced from their home areas and doing it with a smile on their face and really working to keep patients at the forefront of everything they do.
I think from a board point of view, we want to record our thanks, but if there's any way, Dan and Sue, as you're around and about, you can pass that thanks directly back, because I recognise how nurses dislike being disrupted from their home area, and it is a point of grumbling quite often, and I fully understand and appreciate why, as do board members. But it'd be really good for them to know it really is appreciated, and I'm sure you and Dan are telling them that all the while. Our point of view at our level, we really do appreciate, and the smile on the face is the icing on the cake. That says something about the culture in your nursing teams. Okay, thank you. Are we going to strategy, Sue? Do you want to just...
The Nursing Midwifery Allied Health Professional Strategy. I just wanted to give a verbal update. We had an absolutely brilliant session with Helen and the team at our NMCC meeting last month, where we collapsed the entire agenda to do a co-produced piece of work around how we are going to develop our strategy. We used the new Miro tool, which is a virtual flip chart type, post-it type process, and I have to say we had 100% engagement from everybody. So Helen and Dan and the team are now going to take away the themes that we picked up and start to build around our visions and ambitions, our strategy, which will then also be taken back to the team so that we're constantly checking in with them that the wording we're using is the wording they understand, that they recognise, and it is truly co-produced. But I have to say, immensely proud that absolutely everybody at that meeting had something to say, and we felt that doing it virtually might be a bit disabling, but actually I think on reflection doing it virtually was really enabling, because I think people commented when perhaps they might not have done had they had to put their hand up and speak out loud in a forum. So it was a really good way to do it, and I want to thank the Helen and Helena for joining us and helping to pull that together, because it was incredible. So yeah, thank you. Watch this space. We'll hopefully have our strategy written and all nicely published and shiny to bring to the board in the near future, very near future.
Thank you, Sue. We'll look forward to that, but make sure it's not too shiny. Too shiny strategies tend to sit on the shelf and not be used. So if you take my point, it's how it's used, how it underpins what we really do, rather than the beautiful document. Right. Thank you, Sue, very much indeed. Okay, if there's Alan.
So I'm looking at Sue and Clement. In the future, are there any strategic issues about staffing across health and social care In other words, do we see any potential innovative ideas where there is learning across, Clement, your social care teams and our nursing teams, or are they just too far apart for that to be the case?
It's work towards bridging, towards building bridges between the community health and the social care teams, and work alongside Sue and Daniel in terms of developing a program of work that will enable us to maximize across health and social care. So definitely recognize there is work to do, and looking forward to working with Sue and Daniel in terms of developing that.
That's good. Okay, thank you. So, Dan, can I thank you very much indeed, and we look forward to seeing that strategy. Okay, thank you. Could we then move down to the delivery for today, a normal section, and can we move to the Insight Committee? And Richard, this is your committee, and I think you and Craig are presenting on this.
Yes. Craig, I'm not entirely certain whether Craig's starting or whether I'm presenting. Happy either way, Craig.
So if it's okay, Richard, I was just going to do a verbal update on the Insight Committee and hope that that will serve as an introduction to this section of the agenda, which includes the work that we've covered in the Insight Committee, and hopefully this will be both replicated in terms of the other elements of 3 Eyes, and hopefully you'll start to see a thread emerging through the 3 groups. So the Insight Committee seeks to gain assurance over 4 aspects of the organisation's work. So we look at patient access, we look at patient quality and safety, we look at clinical effectiveness, and we look at finance and workforce. There are subgroups that cover each of those 4 areas, and there are so the Insight Committee then seeks to gain assurance over the processes that are in place within those 4 areas. At the last Insight Committee, we focused in particular on patient access, principally because of the concerns, and you will hear that come out of some of the next agenda items, the concern around the wait time experience that our patients are undergoing at the moment, and in particular around concern over the long cancer waits. So what we were doing is gaining assurance over the way in which that is considered within the organisation, and as I said, you'll start to hear some of that in the next items. We had a deep dive around diagnostic weights. So Michelle O'Donnell came to the Insight Committee to talk to us about the work that is going on around diagnostics, and again to highlight the concern that we have in that area. Again, you'll hear more of that coming up. It's fair to say that the other areas that Insight looks at is still developing, so patient quality and safety. Dan spoke at the Insight Committee about the work that he's doing in terms of clinical effectiveness. Ravi will chair that group, but it hasn't yet met. And Ravi and Dan will work very closely together because of the synergies between clinical effectiveness and patient safety and quality. And Nick MacDonald chairs the finance and workforce group. And again, there's some work that's ongoing with both Nick and Claire Sorensen around some of the metrics that we will look at and provide to Insights so that it can gain assurance around the processes in terms of workforce and finance. But you'll see some of those reports coming up as well. So Richard, that was an attempt to cover that. The other thing that came up, I should have said, in patient quality and safety was there was an escalation around the Vre outbreak. So again, that's one of the things that we're looking at within that group. And I think hopefully you'll start to see a thread, because that was looked at in some of the other assurance committees as well. But Richard, is there anything that you wanted to highlight that I haven't picked up?
That was a superb, very much. I guess for me, there were just three sort of messages out of our Insight meeting about how the committee works, and it's dependent on three things. Dependent on data, first of all, and we talked a little bit about the pressures on the data team and what they're doing about that, and some assurance of the processes in place to sort that out. I think it's really important that the subcommittees work effectively and well, and that's, as Craig has said, a process and evolution. And I think it's really important that we understand how to use the committee to be curious. So I think the deep dive into diagnostics was really helpful, and a sort of model of how we can do that effectively in the future. So those are the only things I would add.
Thank you, Craig, and thank you. Any questions for Craig or Richard? I mean, I think we all recognise that the way in which the committees are working is still evolving, but it sounds as if your committee in particular has got a good grip on where it's going and where the focus is. So thank you very much indeed. Craig, as you're already in the chair, I'm going to move you straight to finance and workforce.
Thank you, Sheila. Thank you, Sheila. So you've got the finance report in front of you, so that in terms of the financial position, we continue to break even as an organisation and are forecasting that we will break even for the year. There is still a significant degree of uncertainty around the financial position. And I know how I've reported before the uncertainty around the second half of this financial year. There is now starting to be uncertainty around what's called the Elective Recovery Fund, so an element of the financial performance in the first half of the year. That's where the Department of Health were seeking to incentivise the delivery of extra elective activity in order to recover the waiting time position somewhat. It's fair to say that the NHS in the first quarter of this financial year outperformed the Department of Health's expectations around the volume of elective work, and therefore the Department of Health have sought to revisit some of the financial incentives that they put into the system through fear of overspending. So again, the financial system continues to be tweaked. We are trying to maintain a steady course financially through the turbulence that does exist outside of West Suffolk, and I think principally so that the staff within the organisation can focus on dealing with the operational challenges rather than the financial position. That does mean that some of the focus that we've had in previous years around the cost improvement programme in particular is not as significant this year as it has been. However, you can see that in terms of our cost improvement programme, we did set a less challenging target than we've had previously, but broadly we are meeting it. And you'll notice from the phasing of the cost improvement programme that we had been seeking to deliver a significant proportion of the cost improvement programme in the early part of the year, taking cognizance of, again, the operational uncertainty that sits in the second half of this financial year. Overall, my principal concern, as expressed in previous boards, is around capital. We have a healthy cash balance, and normally that would mean that there is less pressure on the capital programme. However, the Department of Health are being much stricter in terms of organisations flexibility to determine their own capital programme. So we have been set a capital budget. At the moment, I think we will overspend against that capital budget that has been set. So I am talking to colleagues in the ICS and colleagues at Region about that, because that's my chief concern financially at the moment. So work continues on that, but just to highlight to board, that's where my concern in terms of the financial position lies.
Thank you, Craig. I can see there's a degree of turbulence and uncertainty in there. Can I just ask, thinking ahead, and I keep saying about how life's going to be different because of the way we work as a system, do you have any anxieties about statutory ICSs, more pressure on organisations to work more collaboratively, which will include finances, no doubt, with others in the system?
So I think that the way in which the finances will be managed is moving in parallel to some of the other discussions. So we've talked at this board both earlier today, and we will continue, about the way in which we need to consider the quality of access to services across the ICS. So when we're looking at working together with colleagues around the way in which patients are treated, then it makes sense to consider the finances in a similar vein. So we have good relationships with colleagues across other organisations in the ICS. I think the consistency that is offered to the ICS through the recent decision around ICS boundaries is helpful. So we will continue to talk to the same partners we've been talking to previously, and we can build on what are already good relationships. So I think just financially we need to have the same conversations that my colleagues clinically and operationally will be having with their counterparts as well.
Thank you, Craig. Chris, can I bring you in?
Thank you very much indeed. Just a couple of points. Firstly, congratulations, Craig, to you and the team, the finance team. You're doing an amazing job on keeping the finances tight in these turbulent times. Two things occur to me. One is, and I suppose it's very timely with Clement's arrival, and welcome, Clement, this sort of joining up with community and primary care, your comments there, Craig, about a co-produced collaborative approach to care across a system, obviously has profound implications for where money is spent and where money is invested. And I suppose our duty, Sheila, of all of us is to make sure that we are really well engaged in the ICS as that develops. And I know that they're looking for a new ICB chair, I think.
Not for us, I don't believe. I believe that we have continuity.
Great. Well, and that's a huge relief that we do. Perhaps it's Norfolk and Waveney then that's going to have a new chair. The other thing is, I just saw the other day, Craig, that the government was looking to value engineer the new hospital programme and sort of, as it were, get cheaper hospitals. Is that going to impact on us, and are we going to have to redo an awful lot of the good work that you and the team have already done?
Thanks, Chris. So taking those points in turn, absolutely right about the principles that we've always worked to, and actually Steve has been instrumental in ensuring is that across the organisation we do the right thing clinically first and then make the finances work. That's been particularly true in terms of the way we've worked with community services in integrating those services into the wider organisation, and now is becoming true within primary care as well. So that ability to move money around the system to reflect where care should be delivered rather than where it has been delivered in the past. It's one of the things that we focus on. It sounds a lot easier than it is, and it's sometimes difficult to move money around, but a focus on doing the right thing clinically has been the way we've always worked. In terms of the new hospitals programme, you're absolutely right. So the 8 Pathfinder organisations have been asked to produce options that might be slightly cheaper than their preferred option. I think that's probably the polite way of putting it. They are working through that. I think in a number of cases that means a reconsideration of what is the preferred option. So where it might have been a wholesale new build, they're now having to consider options for partial builds. In our case, that's just not possible. So the imperatives that are driving our case is the fact that the main hospital building is past its use by date. So that whole hospital building does need replacing. So in our case, that partial build option isn't one that works. We have had discussions with the regional office along those lines, and they accept that where there might be options for others to deliver a cheaper scheme, that's not the case for us. So we continue to work with colleagues. There will always be pressure to minimise the cost and to make the overall money go further. But we've been following that principle as we've worked through the business case anyway. So it is a further challenge, but one that we're up to.
Good. Okay. Well, anything that we can do to support you in that, Craig, in the wider stakeholder community, let us know.
Yeah, we'll do.
I think for Chris as a newcomer, Craig, it'd be useful for Chris to have some time with Gary Norgate, wouldn't it? And go through the details of where we are.
Very much.
I agree. It's always good to inflict Gary on as many people as we can. So yes.
Absolutely. I mean, we would all thoroughly agree with you, especially as non-exec colleagues.
All right. Okay.
We'll make sure we arrange that.
I let myself in for that one, didn't I? No, right. Good.
You did. You walked straight into it. If there are no more questions, I'm going to move, because you've talked a lot about operational pressures in your report, Craig, and clearly the finance and the operational are inextricably linked. So can I move to the operational, please, Helen?
Thank you, Sheila. As I was writing this, it was quite...
Helen, you're quite faint. I think you might need to adjust your volume. Sorry.
Any better, Sheila?
I'll just turn my volume up.
I think, Helen, as you talk, every time you come on, it does start quieter, but it does get better as you keep going.
Oh, I'm sitting here looking like some sort of airline pilot with a headset on, because I am really struggling with the volume on my kit. So hopefully you can hear me a little bit now. I'm not known for being quiet and in the background. So this is quite sobering if we talk about the general activity levels and the COVID levels. Clearly, the majority of the report is talking about figures in June. That activity level has increased in terms of, has continued through July, and admissions are feeling much more pressured. When I wrote the paper on Friday, there were 5 COVID patients in the organisation. By the time I'd actually submitted it, they were 10, because over the course of the weekend, we doubled our numbers. And as you might imagine, that was quite an anxious time, with all of us really wondering whether we were going to double again very quickly. We have stabilised. We've got up to 11, but we're back down to 8 this morning, so we're hovering around those numbers. But I have to be very clear, we are a bad day and a few more COVID admissions away from needing to replan our bed base, and there is nowhere to go other than our and that is really concerning. And I would have to pay tribute here to the patient flow team, particularly the ED team, but all of my clinical and operational colleagues, who every day at the moment is a really, really tough slog. On the COVID for a while, there is a real mixture. We have COVID admissions. We do have one in critical care today who is ventilated. We haven't seen a lot go through critical care, but we have 1 or 2 patients in virtually every age category. So 25 to 35, 35 to 45, all the way up to over 85. We have a real mix of people who've been vaccinated once, twice, or not at all. So it's really difficult for us locally to draw any conclusions out of that because it's just such a disparate picture. We have a plan that's been signed up to by the divisional teams. We know where we would go to increase COVID capacity should we need to do that. But unfortunately, like any rearrangement of the pieces in the jigsaw puzzle, you do need an empty space to start that move. We have no empty space. And every day now for the last week, we have come into the very difficult position of patients already waiting for beds in the emergency department. So every day this week, we have started on the back foot by up to 12 patients, which is a really concerning position, but is also really, really tough because it takes you to lunchtime to start the day, if you like, and start to deal with today's activity and today's challenges. I can see Alan's hand up, and I'll come to you in a second, Alan, but to finish this section off, we are doing this with the additional pressures of the RAC Plan programme. However, the pressures we are seeing are being felt in every NHS trust up and down the country. So regionally and nationally, everybody is facing these challenges. Our new emergency department specifically created a space to offload ambulances. And we're a bit victims of our own success because we're having ambulances diverted to us because we can offload them. And that is the right thing to do because every ambulance trust in the country is also at the highest level of escalation now and unable to offload ambulances in a timely fashion. So there is some real pressure in the system that is incredibly concerning. There is lots of discussion and conversation about what can be done about it. Particularly, we've had some earlier conversation around this board table about what we're going to do about winter. This is the last day of July and the last month has felt as bad as any winter I've ever worked through. So some radical option solutions, but as it stands at the moment, I don't think people locally, regionally or nationally know what those solutions are because the pressure is incredible. Stop there. If that's okay.
Thank you, Helen. Alan, I'll take you quickly.
Just while you're talking about ED, Helen, as COVID has moved on, have we got reinstated GP streaming in our ED? I'm conscious our previous medical director wasn't highly enamoured by that process, and I wonder if Paul's got a view on it. But as you're saying, there's quite a lot of minors coming in. So are we exploiting GP streaming as much as possible?
So we've never stopped GP streaming, Alan, so I'm sorry if that's the impression you've had. We have reduced the hours in which it operates, but that was done in consultation with the system around when the best, when the activity demanded it. The problem we have, Alan, is that assumption assumes that there's lots of GPs with nothing to do. And actually, a GP streaming shift is really hard going at the moment, and it is quite difficult to fill them. We are managing to fill our agreed shifts that are supplied to us by the Suffolk GP Federation. However, I know in the east of the county they are struggling much harder to fill those shifts. There are lots of additional demands on GPs' time, and I think doing the streaming shift in ED is one of the tougher ones. So it is a workforce supply and demand issue in many ways.
Does Paul or Kate have a view on that? Because it feels like we should put money into that and try and make that happen as an alliance and as a system.
It isn't a money issue, Alan.
No, it really isn't, Alan. I think it's really important to say that, and I think it's also important to Helen's been fantastically honest there about the situation we're facing, and it is mirrored across every part of the system. I think that's the really important thing to say. So from a primary care perspective, I think we're at 120% of our routine activity that we would be expecting in winter, as we're saying in July. So I think it's much more than funding. It's it's something we can talk about separately if it would help me to get a bit more background.
Okay.
So I suppose the assurance for us is the underpinning work being done to try, because actually it's a numbers game in some ways. There just aren't enough doctors to go around to provide everything you need, and we haven't got enough beds. So there is a very simplistic is not the word, but a straightforward issue. And I know that the usual line is we're working on how we do it differently, but actually that's not as simple as it sounds, as we know from previous years. But I'm assuming that jointly within the system, involving social care as well and voluntary sector, are we doing, all that prep work now to do what we can this winter?
Yes, we are doing what we can to try and identify potential solutions. So at the regional coup network meeting, we've extended next week's meeting to do a bit of a round the table. What is everybody doing that's working, and can we learn from each other? And is there any benefit? The ICS have also got a workshop of all partners next week, again to look radically. The regional teams are saying, put forward the unthinkable, nothing is off the table. The problem with that is they've no idea how they are going to fund whatever we come up with, but people are being asked to think different and think radically. And I think there's a real recognition that tweaking around the edges isn't the solution potentially here. So, but yes, lots of workshops, lots of talking, and lots of consideration about what the issues might be.
Thank you, Helen. I've got Richard and then Clement.
Thank you. My concern is that part of this demand is driven by people thinking the pandemic's over and everything's going back to normal. Are we continuing to be effective in the system-wide communication to people about the demands on the system at the moment, and making sure that people do not inappropriately use the services that are under such pressure?
So that's a really difficult one, Richard, because we do continue to rebroadcast both the national messages and to work across the ICS. The evidence would suggest that the one impact of asking people to stay away from ED is an increase in ED attendances. So that's a really, really difficult one. I don't think anybody's really found the message that's hitting home. in terms of use of services and selecting the most appropriate service. But I would also say, again, there's a real perception that 111 maybe isn't that helpful. 111 are also seeing 120, 130% increase in calls to the service. I was told yesterday there is some additional funding at a national level going into 111 services to increase their resilience. Concern around that is, again, it's short term, and whether that is really going to provide a resilient, sustainable solution.
Clement, from a community point of view.
Thank you. I was going to add in relation to the workshops around urgent and emergency care that Helen's made reference to. We are planning as an alliance to formulate a winter plan. We are looking at it as broader than just winter. We're looking at it as more a resilience plan that we will be able to step up and step down accordingly, which will focus on community prevention, the acute as well as post-hospital discharge. So that is currently work in progress, and we should be able to feed back at the next board in terms of the output of that.
That would be very good if you could, Clement. That we'll certainly identify that for the next board. Thank you.
Yeah.
Helen, do you want to any more you want to keep going on?
So I think the bearing extension and the RAC programme is fairly self-explanatory. The only point of note I'd like to just call out there, a really, really good piece of joint working between ourselves and St Nicholas Hospice, who I think you all know share the site, and we've come together to, in a way that I think with our space issues and supports them with a little bit of income in these very difficult times. And we've moved our medical day treatment unit to operate out of a space that was not being used up in the hospice building. They've been there for about a month. Sue and I have both been up, visited them. I have to say credit to the team and the leadership unit manager, Alex Braga. They are really settled, really intensive. They are really making what could have been a very difficult situation work really, really well, and they're loving the environment. So that's really helpful. The other thing I would say, I think, is we are now really starting to as well as clinical areas, and we're moving. A lot of our wards are used to being moved. We moved them to decancer, and they kind of take it in their stride. We're now moving other teams and we're moving areas. And I just want to really call out, there's nothing anybody can do about it other than the fact that we're aware of it and are trying to manage it. But the extra layer of stress on top of already stressing disruption is also playing through a little bit. Very mindful, very sensitive, but it is an inevitable on top of it. And then the final section just talks about the accelerated programme and elective recovery. First thing I would say about that is, you may recall the first time I talked about it, and we were at the stage of apply for accelerated funding, and I think the view was that what was included in the ask for the accelerated funding was exactly the same as was going to be asked of everybody else, but without some additional funding. That is most definitely coming in play. We were aiming to get to higher levels of activity by the end of July, which, although the numbers haven't quite, the books haven't quite closed on, I'm 99.9% confident as a system and as an organisation we have done. But all organisations have now seen the activity requirements step up and are seeing the pressure around the transformation programmes being accelerated. So I think it was to be involved and to try to be at the head of it, notwithstanding the pressures. I'm happy to take questions on the content of that, but again, I think it's fairly self-explanatory. And I've just given you as appendices both the latest levels of activity, and I've included this subject that was used at a recent operational hub system meeting. It's a couple of weeks old now, of course, group meets every week, but it just gives you a flavour of both our activity levels and ESNET doing. There is one red thing, but that is the way it's playing through at the moment, big adjustment to be made to rack back. That's a bit of an anomaly in the way it's playing through. Actually,
Helen, we really are struggling with the volume now, and intermittent. Chris, I don't know if that's what you were going to say.
I was going to say that, but I was also going to just ask Helen if she could help me understand, because one of the things we do tend to get asked is about our waiting list, because that's what people are very concerned about. The sad reality is that we have to set priorities in terms of sort of the impact on people of waiting. And I suppose a lot of people with sort of orthopedic stuff are going to have to wait longer than people with cancer and other things. Can you just say a little bit about how we set those priorities and how we're doing on that, and sort of so we can understand the pressures that are being put on you?
Okay. I'm hoping you can hear me now.
I think, Helen, if you keep facing forwards, it seems slightly better.
The tricky thing is I've got the thing I'm referring to on the other screen, but
I know what you mean. I'm the same.
Okay. So, Chris, all of the patients on the waiting list have now been allocated something called a P code, so priority code. Yep. And that's the clinical assessment of their priority. P1 is basically emergency. It needs to be done within 24 to 48 hours. P2 is largely our cancer activity. So usually within 28 days. P3 then can wait a little longer, and obviously P4 waiting. We absolutely have to carve out capacity for P1 and P2 activity, and that takes first priority. After that, really our focus is on the very long waiting patients. And in both the divisional and the weekly trust one, call them access. We literally go line by line down these patients to look at the longest waiting and is a system ambition to have nobody waiting by the end of this financial year longer than 78 weeks, which sounds like an incredible. That's an ambition that is more ambitious than national ambition. We will struggle locally until we get our additional theatre capacity, and we are also looking to see where else we source additional capacity. But we are now working really very collaboratively with ESNET, so our access leads across both sides are aware of each other's long waiting patients and are giving patients an opportunity, should they wish to take it up, to move in and have their surgery in another location. That's patient choice. But it's been tricky to set up because it requires quite a lot of detailed work around pathways, clinical governance, SOPs. Those are now in place in ophthalmology and TNO. Patients are starting to be given the opportunity as well as to move to the independent sector. And we are now looking at ENT and general surgery. think you're on mute now, Chris.
Helen, that's really encouraging. Thank you very much. And that's really helpful to understand the way that's going. And particularly, I'm really encouraged that this is a sort of an additional support for sort of wider system working in collaboration and getting patients used to the fact that they might not always be able to have, care immediately adjacent to their home, but they might need to travel a little bit further. Thank you.
Absolutely. And just page 58 of Convene, the table there shows you the differential between ourselves and ESNEFT. You will see actually that we are doing incredibly well for the specialties that do not require access to an or an endoscopy. And so it's surgical areas that.
That's brilliant. Thank you.
Thank you, Helen. Alan.
Just to extend that debate slightly more, Helen, a number of us were in some meetings yesterday where several people talked about merging our patient lists, the PTL, within an ICS or across various trusts, and it's actually happening in some geographies. Would you, as a COO, would you favour that? Do you think West Suffolk could work with that, or do you think that's almost inevitable?
So there's a lot of conversation around it. I'm not sure it's happening in geographies where the acutes are separate entities. So there are geographies where there's 3 acutes, but they're actually one organisation. It's definitely already happening there. We are working more along the collaboration and rather than producing one single list, actually focusing on the differentials and making sure we're offering comparative waiting times or trying to move in that general direction. There isn't an awful lot of national guidance yet. It's included in the planning guidance to develop joint PTLs, but what exactly that means and how to do it isn't very clear at the moment. So we're ploughing our own furrow in terms of more collaboration rather than what would be a major an information and reporting point of view to make sure that we could merge the two together. But absolutely, the areas where it's happening is where 3 acutes are now one organisation and they're working.
Okay, thank you, Helen. Thank you.
Thank you. Helen, there's no further questions, so I'm going to move on. We're having such difficulty hearing you. I'm sorry about that. Can we then move on to the IQPR report, please? And who's going first? Nobody. Can we take that as read?
You can. It's included for information. The place where it gets more detailed scrutiny is the Insight Committee.
Yeah.
And that for transparency, we're including it here so that if NEDs or governors have got any questions, happy to answer them or try to.
In which case, it's fulfilled its purpose because it's self-explanatory and nobody has asked any questions. So thank you. And I think we've covered a little bit of that in Insight. So if we could then move on to the integration paper, please. And Kate and Clement, welcome. It's good to have the integration agenda well up the agenda rather than at the end.
Thank you, Sheila. Clement and I are sitting here with headsets on, so I'm hoping after Helen's experience you can actually hear us on ours. It's not a great, not a great advert for the piece of kit, really, I don't think. I just wanted to add my welcome to Clement. It's absolutely, I'm delighted to have a bit of a partner in crime as a dedicated exec in the integration space. And for the purposes of today's report, as Clem's first board, I'll present the bulk of it and he'll chip in for some of the areas if he's got some things to add. So if I walk us through the report and just pull out some of the highlights. And it's interesting, while listening to the debate more generally that we've had already in boards, so much of it is linked, especially when we talk about demand. It's quite a good way of confirming actually how it all links together. So the pieces that I wanted to pull out were, we're doing a a significant piece of work now on the back of the work we started with what are we missing and looking at equality and diversity, and then consequently the work we've done through that to support the vaccination programme with some of our different communities, to make sure that everybody had an equal opportunity to access the vaccine and the support they needed in the right environment. We've also secured some funding to secure a post, which has now been recruited to. She started last week, actually, to give some dedicated capacity to how we work with our different communities, and the focus being on health equity of access to health and care. And this is part of a broader piece of work as well now, a 100-day challenge, because the NHS loves 100 days challenges, that has been kicked off as part of our integrated care system, looking at sort of targeted pieces of work we can do to make sure in all of our decisions that we're making, we are understanding the equity of the changes we're putting in place to our broader population. And it is absolutely fascinating. I think I've learned more in this space in the last 6 months than I have in my entire career. And I think what it's done from a West Suffolk perspective is it's given us really human links into the personalities within each of our individual patches. I think Richard's point he made around how we're communicating with our population around demand, I think engagement is absolutely key to that. I think from a CCG, hospital, county council perspective, we tweet everything. We've got pages that we update sort of almost on an hourly basis at times, but that doesn't necessarily permeate in terms of messaging and people's conversations on a day-to-day basis. That really is impacted by the person they're talking to and the communities that they live in. And I think this piece of work is broader than just looking at kind of discrete pieces of work. It's about the broader engagement model as well. So I'll bring back some intelligence on that when we've identified the sort of target areas. The other piece that I wanted to pull out was around the work on a similar theme that we're doing with West Suffolk College. I think the thing that is enjoyable working as a system is that you have access to vehicles and people that you didn't previously. And our college is a fantastically impressive organisation. And we went to them to sort of say, how do we get the voices of our children and young people into some of our strategic and design work, and just understanding, are we hitting the kind of areas that are going to make the difference to our young people in terms of realising their full potential. So we're doing 2 exciting pieces of work detailed in the paper, which I won't go into much more than that, but looking at what kind of has underpinned their levels of anxiety over the last year and how that's impacted on their outlook, because it has quite severely for some of our young people. And also just understanding, we had one of the tutors who's leading this piece of work would only view this in the positive, which I loved, about getting them to produce work that encapsulates what makes them happy and actually what is fueling their dreams and their ambitions, and then understanding if we can channel that. And they're actual pieces of artwork they're going to produce. So it will be lovely if we can kind of bring some of those into our world and our kind of physical estate as well, because I think we're going to have some impressive work from our young people. And then I'm going to tie the next 2 together. I hope that's not my mic going funny. We've got 2 pieces in here, one around the volunteering strategy, which is a huge piece of work, and we need to make sure it's absolutely linked into our hospital volunteers. And I'm not confident at the moment that it is, but during COVID, during the vaccination programme, communities and volunteering has taken on a whole new meaning. I think it's always been present, but I think it's become a key piece of people's sort of daily lives, and a kind of a symbiotic relationship in terms of, but also the sense of purpose it's given people. So Community Action Suffolk, in conjunction with lots of other partners, is championing this strategy, and it's gone through the ICS, and it will go through all of the alliance committees as well, just looking at how do we operationalise that? What does that mean for our own individual organisations' approach to empowering staff and our populations to volunteer and support each other? And how do we use that as well at a time when we've got capacity issues, and we need people to be as proactive as they can be in terms of their own resilience? That feeds into that brilliantly. And then linked, but not quite the same, is we've been doing a big piece of work again with our voluntary sector organisations, looking at how do we meaningfully change our relationships with them in terms of the commissioning, in terms of how we look at their capacity in our operational model as part of our business as usual. And I think one of the difficult things in the past about that is the continuity of funding. How do we actually put the requirement for this in our baseline? And also they are individual organisations, and very often it can be difficult to engage with them sort of as a collective. And I think what the paper, and I've included the whole charter, which is slightly indulgent, but only read if you are interested in the papers, because they've come together as a group of leaders to say, we realise there's things that we need to do differently to also ensure that we have a correct space around the table. And in 5.4, it gives the sort of core components of that. And I think really exciting stuff, them coming together to share back office functions, them sharing their training investments and looking at the funding model different from our perspective in the longer term, and maybe having just one approach to grant funding rather than different ones on different organisations, etc., etc. This is stuff we've been talking about for years, but I really feel now, again, given the situation that we're in from a demand perspective and the offer that we need to give to our population, the voluntary sector can do things that our statutory services can't in terms of the allocation of time. And we've got some fantastic examples within our West Suffolk patches of organisations that, like the Greenlight Trust, who can take an individual and then hold them until they are back in employment or back in functioning in society, and then stay with that person to make sure if they have a wobble, that they are able to pick them back up and put them back into their system. So it's not about discrete bits of activity, it is about engaging people's lives and talking about how they realise their full potential. And sorry, I realise that I'm going on, it's quite an exciting topic, really. The other point I think I do want to mention, and Clement might want to come in on it, is we're looking at outcome measures. We've got a brilliant quality improvement team in the hospital and in the broader system that influence the broader system, and we're having some really important conversations about the data we're looking at to evaluate our services. And I think very often we look at the complaints and we look at the adverse incidents rather than some of the differences we're making to people to realise their kind of potential in their lives, improve their well-being, improve their quality of life, and working as a team to understand what we could do to evidence that in the way that we evidence our normal indicators, and make sure we get that up to board level so we can see the impact these services are having on people's lives. And I think that links equally to the conversations around the voluntary sector and how we need to think about where we invest resources to be proactive and preventive as much as reactive. And I think that is really going to be the key from a demand perspective and a wellbeing perspective in the longer term. But they're much slower burns, which I think often puts them to the back of the queue. But this again will bring it front and centre for these conversations as a board, which I think will be really useful. Clem, do you want to add anything to that? I've rattled it off.
Okay, thank you very much. Apologies, I lost connection at some point. But in relation to the outcome measures, you're absolutely right. It's really important for us to understand the interventions that we're providing. Kate, you might have covered this when I was when I dropped off the call. But really important. One of the key things we're looking to pick up and prioritize is the work around establishing the boundaries across health and social care. That's a really important piece of work for us in order to help cement the integration work we're looking to progress. We are working on ensuring we have a good understanding of our baseline in terms of our maturity matrix in relation to the integrated in relation to our integration journey, and use that as a baseline in order to measure the developmental work that will take place within the integrated teams. And that is information that we can bring back to the board to reflect the progress that is being made with time. Really important area of work that we are looking to also bring together sooner rather than later is the opportunity of our occupational therapists and aligning in order to maximize the capacity, recognizing how valuable a resource OT is and the gaps we have in achieving that. There is wider work we are looking to undertake, which reflects on making every contact count, delivering the right care at the right place at the right time for the local population, but ensuring that we reduce and minimize the duplication as best as possible within the integrated teams. I'll pause there and invite any particular questions.
You're on mute, Sheila.
Sorry, I do it at least once a meeting, if now it's twice. That was really, really helpful. And there's so much exciting stuff in there. Just two very quick comments. The measured outcomes work, really value. It's what the board's been asking for some time, really important. And I think, you know, it's an area that community services have always struggled in. It's not easy to measure things. Counting beans in terms of what you do doesn't work, never has. But I must just comment, I love the fact you've used some case studies too, because actually it is knowing what the real outcome, what the real impact of services is that matters. That's where we know that we're actually, I was going to say hitting patients, we're actually addressing patient need is a better way to put it. And just an aside, I love the Final Alliance visual graphic. I think it's superb. And I want one for my wall, please. Okay, can we come to Richard and then Alan and then Chris?
Thank you, Sheila. So wonderful paper. Thank you. Fantastic amount going on. It's really exciting and interesting. Sheila's partly made my point, but it's about the outcome measures, which are clearly hugely important to something we've been trying to get, because it not only produces an ability to see what's happening, what quality changes are happening, but also makes it easier to see the visibility of community services at board level. So with that work going on, I know it's difficult. Do you have a sort of sense of timeline for that? When we'll actually start to see quality outcome measures? Is that possible to give us an idea?
Shall I come? John,
Can do, if not I can.
Clem, or you pick it up?
You can carry on, Helen.
I'm sorry, although Clem's doing a grand job here, he's kind of 4 weeks into working with the team, so I don't want to, you know, so I think it's further forward in therapies than it is in nursing, and I think the therapy teams are really gaining some benefit from some of the other programs. It's in, they've only had one group workshop to pull together the thoughts and the ideas. So I think it needs a little bit more work and a bit more discussion. And then the team are also, there is kind of what do we think is the right outcome and what should we be measuring? The next issue is how do we measure and count it? And is it something we already measure and count? So I do think this is a green shoot, but there's quite a lot more work to do, and therefore I wouldn't like to kind of overpromise that this is going to get over the line and we'll give you something next month. I think probably 3 months to allow the team to develop the metrics, come together and agree what they are, and then us work out what we can report and record. So probably 3 months for an update of are we nearly there yet would be reasonable.
Thank you, Alan.
Thank you for that. Alan?
Could I make a suggestion, Sheila and Clement, that at a future board workshop, possibly with governors as well, that we could have a session on just how social care actually works in West Suffolk, which we probably have very mixed understanding of, particularly to pick up the boundary issues that you're focusing on, Clement. I just think it'd be really valuable to get us all up to speed on that offline, Sheila.
I agree. That's a really good idea, and we'll take that away. And I think a combined workshop would be hugely useful. Chris.
Yeah, I think that's a great suggestion, and it's really building on this. What we're looking at is nothing more than major transformational change. There's going to be a huge OD piece around this, massive culture change in terms of expectations of staff, the operational interface between us, sort of within the DGH and these teams that are coming together in the community is also going to be very great. And also patient expectations as well, and working with them. One particular question I have is around use of patient data. And just wanted to make sure, are there barriers in this? Indeed, are there other barriers? Perhaps we can explore this in a workshop, and how can we best support you in terms of this journey of transformation?
Okay. Or Clement?
Let Clement.
Okay, thank you. I do understand that we have already established information sharing arrangements across the Alliance, and would be really useful for us to use that as the backbone in order to enable all our engagement and sharing of patient data as we develop the integrated teams. So I believe that's already established. That's a barrier that we were able to overcome quite a few months ago.
Sheila, can I just add to that slightly for Chris?
Yes,
I think I didn't cover it in the report, but we've done quite a bit of work recently, driven by the kind of system conversations we have around escalation, but also is a historical issue where, as a system and as an ICS, we don't really use data in the way that we should do to manage risk. And we also haven't gone through the stages that probably you would expect if we start talking about being a system, about bringing those teams together. Analysts are such a precious resource. And I think there's a lot of benefit to be gained from looking at that in a holistic way. So working with Craig, we've started that conversation, and all the partners are in agreement that it's the right thing to do. The next thing is really pushing on, okay, what does that look like? Because going into winter without that visibility is a much more daunting prospect. So you're absolutely on the money in terms of anything we can do to take the barriers away. That definitely is one.
And it's certainly a topic that's come up repeatedly at the chairs group. So, if you like, at the political level of buy-in, it's very much there. And of course, that does include the leaders in the local authorities as well, and the voluntary sector. So it's a good place to plant seeds, which can then be carried forward within the system. Okay, I have no other questions, in which case, Kate, can I thank you? Your reports are always full of massive amount of really helpful detail. And I think more and more, how we work with our Alliance, how we work with the wider integrated care system is going to just be fundamental about how we do business on a day-to-day basis. So there's a kind of balance which is shifting. I'm sure at some points it will be uncomfortable, but at the moment I just find it so exciting and achieving a lot of the stuff we've been trying to achieve for the last 20 or 30 years. And this time we're going to do it. So thank you for that. I'm going to take 10 minutes break. We are running slightly late for understandable reasons, but we have taken the nurse staffing report already. So we will take the 10 minutes break so you can go and make a cup of coffee and whatever. And I will see you back at, well, let's say 27, yes, just before past, please. Start. We have had our full 10 minutes. So can I move on, please, to Involvement Committee? And Alan and Jeremy, you've got the reports there. I don't know which of you is starting off.
I'll kick off, and Jeremy can add if he wishes in a moment. I'll take the report as read, but just a few very brief comments. Firstly, I think with Anne's help, we're moving to a world of assurance and deep dives, really, to look at how things are embedded in the organisation, rather than this committee being based on decisions or analytics or reports. So last time we talked quite a lot about our equality, diversity and inclusion efforts, particularly talking about our network groups, Black, Asian, minority ethnics, disability and LGBTQ. And we also talked about our values and the way those are developing. And I think with Jeremy's help, we've tried to think about how the lived experience of these things actually exists in the trust and whether they're embedded rather than the facts and figures of them. So I think we're making progress on that. As I say, Anne will help us transition this and the other committees, and we'll be talking a bit more about that later. Before I pass to Jeremy, though, I feel it's probably worth logging that we are having some input from our governors that they're not feeling entirely involved in an appropriate way in everything at the moment. And I feel it's only fair to recognise that in our minutes, that they've given us feedback that the irony, having an involvement committee, one of our key groups doesn't feel completely involved in all the right way. And I think really, Sheila, we're on a journey to try and listen and think about how we can address that in a number of ways going forward. But I think it's right to recognise that as a group.
Thank you, Alan. I think that's both for the board to discuss and the board to discuss, more importantly, with the governors.
Yeah.
So definitely moving forward, something we need to pick up, and we will do.
Jeremy, as we transition to your overall report, is there anything you'd like to add to what I've said?
I would particularly want to pick out the very helpful challenge the committee provided to me and my team around the leadership work we do with the EDI agenda. There is much content to the statutory reporting and analysis that exists within the annual reports that we provide, both our own internal reporting, but also that to the national NHS requirements with the RES and DES reporting that are briefly referenced in the paper. The next step for this really is to pull out in much more detail where we think our areas of greatest opportunity and challenge are for the board to further take forward this work. There are also some practical steps that are wrapped up in all of that around the capacity of our network chairs to do their particular roles. So these are things that we're currently working on and we'll keep you appraised of. I believe the annual Equality, Diversity, Inclusion report to the board is due in the autumn, so that's quite timely. So it won't be too long before we bring that to you. In my report, there is an example of where the Involvement Committee can do some further work. So I've made reference in my report later on to the emerging integrated care academy that the university is leading on. We want to be an active player in the development of the integrated care academy. It is fundamental to the future workforce development in health and care for Suffolk, and I think there's an opportunity there for the Involvement Committee to really get under the skin of how we can deepen that relationship, both at a strategic level and in practical terms. If you haven't seen it, in the appendices I've given you an update from the university on their progress to date for your background reading. Joe asked a very pertinent question at the start of the board in relation to long COVID, and there is an update in my paper there on some work that is very current. There are a number of experts in the organisation that we brought together to consider how we are supporting both staff and the managers of those staff who are suffering with long COVID. We are currently aware of 10 members of staff who continue to be absent due to reasons of long COVID, and we are following each individual case up. Of course, each individual has their own circumstances and their own challenges, so it is very much not about providing a blanket approach, but by providing individual level support and planning for how they might be rehabilitated back to work, and that is happening. I'm very grateful to Richard as our Guardian of Staff Wellbeing for joining that session in June, and there's some detail in my paper there as to the work that's going on both locally at West Suffolk and across the system. We provide an update on a quarterly basis to the board on appraisal and mandatory training, and that month, this month, that is due, so I've provided that to you here. Overall, we are meeting targets with our mandatory training requirements, which of course is all about safety and making sure that our staff can demonstrate knowledge and skills in relation to a number of topics that are all about safety. We delve deeper than just looking at the top line, so we look at it divisionally by staff group, by topic, and in the appendices you've got some data there to give you assurance that we go to that level, and also some information as to where we are in compliance terms just falling short. So that helps us to focus on the hotspot areas, and I can answer any questions there. For appraisal, we have data and trends also in the appendix for your information. We are around 9 percentage points short of our target. That is continuing to be a slow recovery. Some divisions in the last month have fallen back a little bit. Every division is busy. Every division, including our corporate teams, have much on their plate. However, our corporate division does have the lowest compliance in terms of appraisal. We really do need to lead on this, so that is something the exec directors have already agreed will be given earnest attention. The HR business partners continue in their role to support the divisions with scheduling, appraisals, and providing advice around all of that. You have also in the appendices the latest quarterly required report from Francesca as our Guardian of Safe Junior Doctor Working Hours. And Paul and I can pick up any questions from that report. We had, I think the last one we had was the full annual report. This is a quarterly update. There's a note around our volunteers. There's one consultant appointment from the last month that is noted in there. Dr. Bull joining as haematologist. And finally, to champion and to appreciate contributions of individual members of staff that have really shone through the nominations we've received for our Putting You First awards during the course of the last month. You have citations on page 106 in relation to Fran Sunderland, working as our Pathway 1 therapy lead. A real, even just a short citation, a real illustration of the work that goes on, sometimes behind the scenes, to make integration happen. And there's a really lovely nomination there from Kevin. And on a more personal level, for a member of staff who was also a patient, you have there a nomination for Jackie Brown, board manager on F11, in relation to a member of staff who was receiving care, and the extra steps that Jackie and team went to really take care of the particular family circumstances there that Brittany had. another shining example of our staff going the extra mile to meet individual needs, which is what it's all about. Thank you. Very happy to take any questions.
Thank you very much indeed, Jeremy, and thank you for your report. Yes, it's not quite the same clapping on the screen, but thank you, Helen. We do miss the meeting together, don't we? Because they are people we want to celebrate, because they live the culture that we want to establish, and that's brilliant. So I think having those real examples, like having case studies, does remind us of that. Questions for Jeremy. I think safer staffing comes under your report, Jeremy. Are you going to pick that up separately? Because there was a question on it. Or somebody in the...
So if this relates to the junior doctors' safe working
in that
hours,
case, it's Paul.
Then it could be Paul or I.
Paul, would you like to deal with that one, and then I'll bring Alan in?
Yes, of course. So this is in regard to the latest Guardian of Safe Working report. I've had regular discussions with Dr. Crawley, who, as you know, is our Guardian of Safe Working, also Kajik Baumik, who is our Foundation Training Programme Director, as well as Pete Harris, who's our Director of Medical Education. So there is a concern with the new group of junior doctors because their training experience will not have been without an impact from COVID. So we are clearly minded to be very careful in terms of this induction of junior doctors. So in addition to the usual programme of checking in with the junior doctors that would include regular induction sessions, initial feedback sessions, also the deanery survey, we're planning to survey the junior doctors a month into their role to check in to make sure that they are receiving the necessary support. There are other layers of support available through the educational supervisor, through the clinical supervisor, through the Guardian of Safe Working role. There's also a WhatsApp group that the junior doctors are involved with oversight from the fantastic Helen Croon in HR, where juniors can post any concerns that they have. So there are a layer of areas that we can gain assurance that the junior doctors are getting the best experience that they can. It is going to be challenging. There is absolutely no doubt about that. And I think we do have to recognise that the junior doctors that are going to be starting in our organisation this year are going to have had less hands-on training than those previously. I think that's really all that I can say at the moment. Okay, thank you very much indeed. Alan, can I bring you in with your question?
Jeremy, just to briefly go back to page 114, the National Staff Survey on our health and wellbeing. How it just, I feel quite anxious. We deteriorated quite considerably when the rest of the sector has actually improved, so we can't blame COVID. And I know you're going to look at it some more, but with all the mental health efforts we put in and other initiatives, it does seem shocking that our staff are continuing to downgrade us on this. And I just, can you say just a little bit more about what you're doing to explore it?
Yes, so one of the areas of focus we had through Involvement Committee was looking at the work of our Staff Health and Wellbeing Steering Group. So they are the group that will be doing the work on this. Denise, one of my deputies, is our senior lead. The staff survey throws up a whole raft of data. It sometimes feels impossible to know whether things you do or don't do actually cause the change in percentages. There are lots of factors as to why percentages will shift around in the staff survey, and we know across the board pretty much we had a worsened set of staff survey results, particularly this year. So from talking to my team, I know they are anxious about this too. We do have, conversely, we have some really positive feedback around the significant investment in the staff psychological support service, which is, I think, further than most organisations have gone in investing in staff psychological support, particularly during the pandemic. And we are currently running a survey of staff to help us evaluate the impact of that service in particular. So I'll be in a position to share the results of that with the board at some point in the next month or so. And the work of the steering group continues to involve staff and staff reps in planning in planning other measures. The only other thing that I would say is that the procurement of a new occupational health provider provides a really significant opportunity to review and improve the support that occupational health provide to our staff. So we will have a switch in occupational health provider from the 1st of October to a different NHS-led provider, and I am confident that change of provider will help us together in partnership with them make further improvement.
Thank you. That's really helpful. Thank you.
Okay, thank you, Alan. Helen.
Just following, thanks Sheila, just following up on Jeremy's point and Alan, your question about health and wellbeing. So we have done significant communications this year on health and wellbeing, including developing our own branding around health and wellbeing, ensuring that there's a section in all of our staff comms. So green sheet every week, our staff briefings, the all staff update every fortnight. We're starting our Love Yourself week, which is now going to be a twice yearly event, you know, advertising the Abbeycroft leisure thing. So I think we have done a huge amount of work as the comms team to try and get those messages out there, including advertising the Wellbeing Wednesdays, the staff support psychology team. So I'm hoping that will pay off in some way, shape or form, along with all the other good work that's going on.
Thank you, Helen. That's all great stuff. I mean, I think as well as evaluating the progress on the high figures like the staff survey, it's important to understand which of those initiatives is hitting the sweet spot, if you like. I'm not suggesting we don't do the others as well, but it'd be nice to know where the best results are coming. Okay, any other questions or comments on Jeremy's report? In which case, Jeremy, thank you for that. I know you have another meeting to go to. We'll see you back later. Okay, thank you.
Group so that we can review it in 3 to 6 months to make sure we're making the right level of progress. So I'm hopeful that will give you the assurance that we are looking at both what we're doing well and what we're not doing so well, but also the fact that, as Craig picked up through the Insight Committee, the VRE figures were a worry. We have already simultaneously got it through the Improvement Committee as well. And I don't propose to say much more about the Improvement Committee per se. It is work in progress and ever evolving, but happy to take any questions or comments.
I think looking at the screen, Sue, I think you can move straight into the report, the other reports, please.
Okay, so I'm going to hand over to Karen for her maternity report, and I'm hoping that she's here. Yes, I can see her. So I'll hand over to Karen with no further ado.
Welcome, Karen. Nice to see you again.
Thank you very much. And also I'd like to, if that's okay, just introduce Justina, who is the new Deputy Head of Midwifery, who started this week. So yes, sorry we are wearing masks, but yes, so Justina is now here.
Welcome, Justina. It's nice to have you aboard.
Thank you very much. It's lovely to be back. Thank you. Okay, so hopefully you've all received my paper, and I will take it that it's read. Again, I can only apologise for all of the attachments. I'm so sorry, but obviously there is a high level of information that I need to make sure that is shared with your good selves. First thing just to bring to your attention is e-care. You'll probably see that we have now got some clinical stats coming out, which is fantastic. There is a little bit of a delay, but they are coming now. So I just obviously just wanted to make sure that I had brought your attention to that. Moving forward with the paper, and just coming on the tail end of every of your last discussion as well. The mandatory training from a our 3 key mandatory training days have kept going, and we are above 90% compliant with all staff groups for those, apart from prompt with the anaesthetics, which is coming up, which is really good. Also, you will notice from the SPC charts that we have got an increase in our postpartum hemorrhages, but that is absolutely to be expected when you have got an increase in inductions of labours and also caesarean sections. They will kind of all go together. What will also happen from that, you have then got increased acuity, so that means our women are staying in longer. So instead of going home after 4 to 6 hours, they are actually staying in for 24 hours. So that these are all things that are impacting on our staffing. Has anyone got any questions?
Thank you, Karen. Questions, anyone? I think it's fairly self-explanatory at the moment. I mean, I'm glad you explained the postpartum hemorrhage, because I was wondering why that had gone up so much about it. I get the logic. Chris?
Thank you, Sheila. Just quick question. I don't know whether it's a relief or just sort of a shared pain of this is a national staff shortage. To what extent are the staff shortages actually currently created by the pingdemic?
They are very sporadic. So, for instance, it was 2 weeks ago. We had over 12. We had 12 members of staff who were off. Some very few had been pinged. I think we only had 2 that had actually been pinged. I think when we looked at it, wasn't it? But lots of them. We haven't had positive staff. It's all been family members either being symptomatic, waiting PCR tests, or have got positive PCRs, but not actual staff. It's their family members, household members.
Thanks.
Thank you for that, Kate.
I just wanted to add in for Karen and the wider team's benefit, and I don't know if it is a benefit or not, but at the CCG board on Wednesday, Lisa Nobes, who's our lead nurse for our ICS and heads up quite a few of the regional pieces, was so incredibly complimentary about the West Suffolk maternity team and just the volume of work that is being carried out, the progress being made in, as Karen's brilliantly outlined, an incredibly challenging and almost, well, unprecedented situation. I think it is really important to make sure that we are just remembering there is a lot of really solid progress that's being recognised, I think, by all partners. At a very difficult time, but I think it's important to put that colour into this conversation as well.
Thank you, Kate. That's really helpful. And I'm going to bring Paul in a minute, because I think from a welfare point of view, and I saw you nodding at Kate's comments, I think there's a real need to make sure with that volume of work and the pressures that we do all the supporting of the staff that we can. I'll bring Sue and Helen, then I'll come to you, Paul.
Thanks, Sheila. And I just want to recognise that in addition to all of these pressures, Karen and the team have managed to submit our CNST requirements and continue to meet all of the national requirements for data submission, which is incredibly high level of information that we need to do. And also at the recent continuity of care ICS meeting, we are currently on track to deliver our continuity of care plan by the spring next year, and I think that's a really, really robust and positive step in the direction of maternity services. So just want to say that although it has been extremely challenging, it hasn't stopped Karen and her team from doing all of the fantastic work that we've needed them to do. So just a big thank you.
Thank you, Sue. And Helen?
Mine's a slight sideways issue, Sheila, so I'm happy to wait to the end if you want to.
Okay, I'll bring in Paul now, and then Steve, and then I'll come to you, Helen.
So thank you. And just again to acknowledge the extraordinary work that is going on in maternity. I have to say, before I started as the medical director, I wasn't a familiar presence on the maternity unit. It's been a revelation to me. I think fundamentally one of the really important roles of the board patient safety champion is to look after the well-being of the midwives, so that the midwives can look after the well-being of our patients. And what I'm really keen to do is use a broadly similar methodology that I did when we started the doctor wellbeing work, namely to survey where our midwives are in terms of their wellbeing at work with a relatively simple 1 to 10 scale, to ask our midwives to iterate exactly what they find the key issues are around that are impacting on their wellbeing at work, and then even more importantly, to find out what the midwives feel are the ways that we can actually improve wellbeing at work. Now, of course, some of those will be, we need more midwives, you know, there are some very obvious things, but what I'm really hoping is that if we frame the questions correctly, we can get some areas that we can actually really intervene on, so that we can have a "you said we did." Now, that is going to be challenging in the current situation, but what experience has taught me is that even the exercise of surveying and listening attentively and understanding what the issue is can be beneficial and helpful. So what I want to do is really work on the communication of that. So rather than just sending out a single email survey, to work on actually engaging with the midwives, championing it, getting the comms out, and then launching the survey with regular reminders, at least a 50% response rate, because that will give us the ability to say that actually the results that we're getting resonate across midwives, rather than just representing a few individuals. So that's work I'm really keen to get engaged with in the next month or so. And I've already been working with Sarah Turner, the outstanding HR lead for women in midwifery, on developing the survey itself.
That's fantastic. Thank you, Paul. I'll come back to you, Helen.
Thank you, Sheila. Just I wanted to say, just as I step down, a big thank you to Karen for all she's done. Another tremendous set of board papers, another tremendous, shall we say, set of deadlines observed and submissions made. In a context of quite a challenging, shall we say, environment. We've talked about the staffing, and there's been huge scrutiny on the maternity team post CQC. I just want to say a big heartfelt thanks for all you've done, Karen. I really appreciate it. We're lucky to have you, and you're doing an amazing job. And it's not easy coming to the board to report every month. So thank you ever so much.
Oh, no, thank you, and thank you for all of your support, Stephen. Yeah, thank you.
Thank you, Karen. And finally, Helen, you get the last word apart from the chair.
Thank you, Sheila. And it's not about Karen's report particularly. I'm just really uncomfortable around this forum of us using terms like pingdemic. I think it suggests that we've got a digital problem. What we've got is a pandemic problem and high incidence of case rates in the community and as a healthcare provider. I would hope we don't use the term in the minutes of the meeting, and I think we just need to be very careful around politicised language.
Thank you, Helen.
Thanks,
that
Helen.
was lazy terminology of me, so my apologies. And I'll make sure George doesn't put that in the minutes.
It was me, Sheila, who used it.
I think I used it as well, so I think we'll both take ourselves as reprimanded, don't you, Chris?
Absolutely, slap on my
Beautifully.
wrist. Thank you for the
Thank
guidance.
you, Helen. Karen, thank you for that. Unless there's any other questions, I think it is fantastic work, and I don't want you to feel, because we say that every month, because the volume of detail and material you bring to us, the way that every month you've made that progress, in spite of all the restrictions around staffing, around so much context that's difficult. I don't want it ever to feel that you just come and we say thank you again, because it doesn't feel like that. We are immensely proud of the work you and your team do, and I'm really pleased that Paul is looking at that welfare aspect, because any team under the kind of pressure your team are under is going to creak at times, inevitably. We want to be as supportive of you as a team as we possibly can, because you're a great team. So thank you. Okay, thank you. I see we've got Andrew Dunn arrived. Andrew, can I suggest, Sue, would you mind if we did infection prevention after the junior doctors?
Not at all.
Because I'm conscious, Andrew, you're between patients, and patients are what matter around here. So I'll hand over to Paul and Andrew.
Okay, thanks, Sheila. Thank you. Paul, do you want to make a start?
Yeah, I'll just introduce. So I was really keen that Andrew came to board to present this paper. I know that Sheila and I, you talked about increasing the involvement of our clinical directors at board. So I will now hand over to Andrew to present this paper, which, as you know, came through the board. I think it was 2 boards ago when there were discussions around the experience of junior doctors that were highlighted through the Guardian of Safe Working report. So Andrew and Simon have done a huge amount of work on this, and this paper is the synthesis of the work in the last couple of months, and indeed several months of work as well.
Thank you, Paul. Over to you, Andrew.
Okay, thanks.
And welcome.
Thank you. So for those of you that don't know me, I'm Andrew Dunn. I'm an orthopaedic consultant here at West Suffolk. I'm also clinical director of surgery. So we'll take the paper as read. The paper's titled "Supporting Junior Doctors Out of Hours in the Surgical Division." And the paper describes the actions that have been taken to date and the future plans to support the junior doctor workforce following concerns raised by the junior doctors themselves and the Guardian for Safe Working. And so in the paper, Simon and I have set out the situation, the background, the feedback and information gathering we've done, which has come from multiple sources. It's come from the first-hand experience of the junior doctors themselves. It's come from surveys that they've conducted. It's also come from the general surgical consultants who have shadowed the junior doctors during their shifts to, really understand what the issues on the ground, are and how they can support them. There's then quite a detailed action plan, and then a section on further actions required in terms of recruitment, training and experience, and then financial implications of those further actions. So to take you back to the recommendations, number 1 is that the board are asked to accept this report, recognising the progress that's been made to date with the issue. Number 2, that the board are asked to acknowledge the need for incremental change and evaluation at key stages of changes to support the work, and that the board support the change in the junior doctor's rota to remove the 7 till 8 o'clock 1,500 hours to the 2,000 hours gap, and this change is evaluated for its impact and effectiveness before it is moved to resident on call rota for the general surgical registrars. Happy to take any comments or questions.
Okay, thank you, Richard.
Thank you, Andrew. Great paper and really
I then move back, I'm sorry, I'm dotting around today rather a lot, but back to the infection and prevention, please. Sue.
Thank you, Sheila. I'll take the report as read because I know that we are short of time now. Just really to highlight, I've got an echo, I'm not sure why.
Okay,
Okay, just to recognise that we have, just for assurance, we've done an audit on our COVID routine swabbing data, and you will see that we maintain good compliance against our day 5 to 7, and our day 3 swab needs further work on it. We've presented this to the Nursing Midwifery Clinical Council, and we'll continue to monitor it going forward. And I'm happy to take any questions.
Thank you, Sue. We're having trouble with your sound quality as well. We seem to have a real sound issue today, but are there any questions for Sue? I think we'll take that as we can move on. So can I come down to Future Systems Board report? Craig.
Thanks, Sheila. Again, you've got details of the work that's been ongoing over the last month, principally the work around communicating the planning application and the engagement exercise we're going through, but happy to answer any questions.
Okay, thank you. Again, I think the report is fairly self-explanatory, good progress, keep you updated. Okay, thank you very much indeed. In which case, Anne, can I come down to the governance report, please?
Yes, again, we can take the report as read. It's important to record for the minutes that we have used the trust seal and that we have exercised emergency powers in between board meetings, and to recognise that we've been through the correct process with both. We have also concluded what needed to be done on the quality accounts, and they are now available and in the public domain so that people can view them. Unlike the annual report, where there's a process we have to go through, the quality accounts are now separate from the annual report on accounts, and we don't have to wait until the publication of that document before we can read that. That's all I wanted to say. Happy to take any questions.
Okay, thank you. Are there any questions for Anne? I'll take it as not. I'll move straight on to the BAF, please, Anne.
Yes, this was last reviewed by the board in February, and we've now moved the discussion of the BAF to the public meeting because it's appropriate. We've updated the board assurance framework, and in the process of updating it, I have assigned or have linked the risks in the board assurance framework to the assurance committees of the board, so that they, I suppose, maintain the eye on the detail in terms of how we're managing these risks. During the process of doing that, I observed that we have reached our target risk for the pathology, management of pathology risk, and I'm recommending to the board that that be referred to the improvement committee for a decision on de-escalating it from the board assurance framework. Also, the risk relating to partnership in the alliance has reduced, but it has also changed. So I'm recommending that that be referred to the involvement committee for a decision on de-escalation. Happy to take any other questions on the board assurance framework, but I think the board assurance framework is an essential tool to help manage the agenda of the board, but also the assurance committees feeding into the board.
Thank you very much indeed, Anne, and I do welcome it being in the public domain now. I think that's really important. We always commit to putting everything in the public domain we can, and I think, you know, that's a move in the right direction to have reassessed that. Really good to see pathology being recommended for moving. It's been a long journey. Alan.
And can you explain to me, is there an appropriate place in the BAF to recognise the stresses and strains and transition that this board is going through in itself? I know we can talk about that in other places, but I feel we should recognise in public that the board is under stress and going through an important transition. And that is a risk, I believe, to the organisation, its reputation and the way we work. And should that be in the BAF?
Elements of the transition risk have been risk assessed, and we have discussed them at the management team. We do not believe that they are sufficiently high to merit inclusion on the BAF at the moment. But I think I'm happy to take that away and discuss it further with my management colleagues, because there have been further changes since the risk assessments were put together.
I think that would be the appropriate thing to do, Anne. Okay.
I can agree with that. I'm sort of happy. My judgment would be that it should be a board decision, not a management decision, but that's something we can discuss elsewhere if you like.
I think it's the management discussion first, and then we may need to make a decision on the recommendations. Is that right, Anne?
Yeah.
Thank you. Okay, any other comments from anyone? In which case, thank you, Anne, and as I say, good to see that in the public domain. Nobody has brought me any other items of business, thankfully. Can we note the date of the next meeting, please? And can I move, please, item 20? And we reconvene, please, in just under half an hour as a board group. Okay, can I just say again, welcome, Clement, and thank you, Steve.
Thanks, everyone.
Bye.